Slidell Memorial Hospital, your hospital for life.
Hello and welcome to another edition of HealthQuest, St. Tammany's response to meeting the medical information needs of you, the citizens of our parish. My name is Bruce Clement. I'm the executive producer and host of the show. It is our pleasure to welcome back Dr. James Butler. Dr. Butler is here today to talk about a surgical procedure called TLIF. And we're going to get into everything about a TLIF and what it looks like and how it benefits his patients. But a little bit about Dr. Butler. He's been practicing for almost 35 years now. He's a graduate of Tulane University. He got an engineering degree before going on to medical school, and where he discovered his love for mechanical type things. And of course our spinal column is a mechanical device. And been practicing. He's now in the SMH Physicians Network, practicing in Slidell, Louisiana. Dr. Butler, welcome back to the show.
Good morning.
So we talk about what is TLIF surgery. What's your definition of it?
TLIF surgery describes the term transforaminal interbody fusion. Transforaminal refers to the way that the surgeon gets to the spine in order to insert a device to serve as a spacer in between the vertebrae. In other words, to replace the disc. Interbody means that you're placing a device between the bodies or the vertebra. Additionally, a second part of the procedure involves the insertion of hardware, usually called pedicle screws, to support the spine internally, increase the speed of the fusion and the likelihood of a successful operation.
So from what you just said now, there are several different approaches, aren't there, to go in and to perform spinal surgery. You can come in from the anterior, the posterior, and is transforaminal, is that from the side?
There are different approaches or ways that you can get to the spine if a surgeon feels that a patient needs to have a spinal fusion, if the indications exist for them to have a stabilization of their spine. A surgeon can make an incision on the front of the spine or on the belly or abdomen and approach or get to the disc space from the front in order to remove the disc and replace the disc. We can go from the back of the spine or posteriorly, the more common surgical incision, and insert hardware from the back of the spine in order to perform a fusion. There is even a new technique where you go straight from the side of the spine, called a lateral fusion, and insert hardware. But all of it is aimed at trying to replace a damaged or diseased disc and give more stability to the spine.
And commonly, the patient population that you work in is the adult population.
That's true.
And that's where you work on either the two major types of conditions that would lead someone to have surgery with you. Would be trauma or some type of injury.
True.
And some type of congenital or de novo type illness that comes on.
That's true. There are various types of problems or conditions and classifications of patients. I see many patients that just develop spinal problems with their normal day-to-day activities. Of course, there's a percentage of patients who have some type of injury. Sometimes they think it's trivial and then begin having spinal pain, or sometimes a significant injury leading to a spinal injury. There are folks that develop problems just as a normal part of the aging process. We call that degenerative. It may just cause a wearing of the disc or arthritis to form in the spine, and sometimes even cause deformity or abnormal curvatures of the spine. So there are different types of conditions or classifications that lead to patients coming to see me for spinal pain.
What about osteoporosis, Dr. Butler?
Osteoporosis, or what people call a loss of calcium from the bone, is a condition that we all get. As we enter into our 30s, we all start losing calcium from our entire skeletal system, from all of our bones. Unfortunately, women lose more calcium at a faster rate than men. Women tend to lose calcium at a rate of about 2% per year, whereas men lose calcium from their bones at about only a 1% rate. So women are losing calcium from their bones faster than men, which is one of the reasons why there are more women that break their hips. With regards to spinal surgery, the development of osteoporosis further complicates or makes the surgery more difficult because the bones are not what they used to be. They're, as people might say, soft.
Right. And so one thing that sets you apart from other surgeons is the technology that you use in the procedures themselves. So on our slide here, we talk about the different pieces of equipment that are used. And why don't you take us through what this equipment is and what it does and how it benefits the patient?
On the slide, the device farthest to the right is what we call an O-arm. It's called an O-arm just simply because it looks like a giant O.
It looks like a donut, just
Correct.
saying.
It's essentially a portable CAT scan machine that we use in the operative field or in the operating room under sterile condition that makes a live, real-time CAT scan immediately while the patient is being operated on. The other devices to the left are various monitors that the X-ray technician utilizes and that the surgeon and or his or her assistant uses in order to watch what we're doing while we're inserting hardware into the spine.
In my reading on how this technology helps you, I read something that it's like having a navigation system like in your car telling you where to go or showing you where you're going, and also a GPS location. How does that work as far as combining those two technologies, and how does that help you?
If we look at this spinal model, this is a model of the lumbar spine. The way that the technology works is we place a device in an area where we're not operating, and it's basically a monitor that communicates with a camera that's attached to a computer, and then the computer is attached to the O-arm. This monitor allows the computer to know where the spine is exactly to within 1 millimeter of discrepancy. We then perform a CAT scan during the procedure, and then we use various instruments and point them to different areas of the spine, and this allows us to insert hardware while looking at the hardware going into the spine.
So we have, in the past, you would use C-arms, which is fluoroscopy, right, or X-rays, and it would take maybe many shots to be able to see how you were progressing in that particular case, adding to the amount of radiation that everyone in the room got exposed to. So the benefits of this would, one benefit of course would be a reduction in the amount of radiation that everybody in the room gets exposed to.
That's true. In a surgeon's career that may span 20 to 40 years, of course, particularly in orthopedic surgery, we do a lot of X-rays and we're subject to exposure to a lot of radiation. In an operating room, when a surgeon is doing spinal surgery where hardware is being inserted, there can be an enormous amount of radiation that everyone in the operating room is exposed to, meaning the patient, the surgeon, and the operating personnel. So if we can reduce the exposure to everyone, we diminish the risk of problems due to prolonged or repeated radiation exposure. Right. The navigation device significantly reduces the radiation exposure. Absolutely.
And safe to say that, you know, we don't want to dismiss the fact that folks are wearing protective garments, lead shielding as much as possible, you know, aprons and gowns and such things. So what type of person is a candidate for this T-lift procedure?
Most often I see patients with either degenerative or traumatic problems with their spine, meaning that they've developed spinal pain because of just age or wear and tear, or because of some injury. The injury has caused their spine to be structurally weak, or sometimes we call unstable, and that abnormal movement of the spine causes pain. one of the most common conditions is called spondylolisthesis, where there's a misalignment of one bone with respect to the other. This is a common problem that develops as a part of the aging process and causes both back pain and leg pain or numbness. When the surgeon feels that a patient needs a spinal fusion, they're essentially telling the patient that that level is moving abnormally and needs to be stabilized or fused. So that's a very common condition, spondylolisthesis, with regards to performing fusions. In other cases, the disc, which normally is very spongy, if you will, has about 75% water in it when we're 25 years old, and as we get older, we lose some of the water content out of the disc, which means that the sponge gets harder and less flexible and may become painful. So in those cases, when people have back pain caused by a disc that's degenerative or worn out, we can eradicate their pain or get rid of their pain by putting in something to replace the disc.
In the degenerative disc situation, does the pain generate from the vertebra being bone on bone, or is that because nerves are being involved?
There's several factors that can lead to a patient having pain from a degenerative problem. The first thing is that the disc actually has nerves that innervate or that act as sensors on the outside of the disc. So as the disc wears away, those nerves become irritated and you can have what's called discogenic pain, or pain that comes from the disc. When the disc also narrows, it causes arthritis, or what we call hypertrophy of the facet joints, which are the small joints in the back of the spine that aid in movement. There are also nerves that innervate or act as sensors from the facet joints, and that can cause pain if those facet joints are arthritic or malaligned. So all back pain is not caused by a people call herniated disc or pinched nerve. It can come from the disc having worn out or from arthritis in the small joints.
Now, what about a herniated disc? When we say this disc is herniated, what does that mean?
This is a model that shows a herniated disc. The red portion of the disc is a portion of the disc that's moved out of its normal location and come to lie against or touch a nerve. You have to think about a disc as being like a jelly donut. There's a center part that's very soft, and then there's an outer part called the annulus that's more firm. When the center part or nucleus breaks out of the annulus or goes through the annulus, that's what's called a herniated disc. If it comes to lie against or touch a nerve, it can cause not only back pain, but back and leg pain. If the disc herniates but doesn't touch a nerve, it can still cause them to have back pain.
So when this nerve is involved, when this disc is touching this nerve, that is when pain, that is one of the causes of pain.
Yes, it's called a herniated disc. Some people use the term slip disc or ruptured disc, but it all really means the same thing. Pain is actually caused by two factors when you have a herniated disc. The first one is the mechanical pressure that the disc places on the nerve.
It's pushing on it.
It's a mechanical pain. The second cause of pain is that when this disc herniates, it releases certain chemicals that serves as a chemical irritant to the nerve, and it chemically irritates the nerve. So you have mechanical compression of a nerve and chemical irritation of a nerve that causes nerve pain.
So it's not always one singular thing that creates the pain in the back, right?
Correct. It's multiple factors.
And is there such a thing as recurrent disc herniation?
Yes. Patients sometimes confused when they come to see me or tell someone that they took a bad disc out my back. They have the misconception that the surgeon has removed the entire disc, when in reality they've only removed the part of the disc that touches the nerve, since you want to leave a little bit of the cushion or as much of the cushion in between the vertebrae as possible. If you don't, in an attempt to take the whole disc out, you just accelerate the degenerative process, and even though you may have gotten rid of their sciatica or leg pain, you may cause them to have back pain if you take too much of the disc out.
Wow.
About 5% of patients, unfortunately, who have disc surgery or who have herniated disc can have a recurrent or a new disc herniation at a later date.
The same vertebra.
In the same disc space,
In the same
between
disc
the
space.
same vertebra.
In between the vertebra.
In between the vertebra at a later date.
Okay. What are some of the symptoms of disc degeneration?
Typically, the most common symptom of disc degeneration is just a chronic or long-term back pain. The degeneration, if it involves nerve compression, in addition to back pain, may cause pain or numbness or tingling or burning or weakness in the legs.
Can, after these types of surgeries and recovery, people tend to go on to a more normal type of activity?
You can't promise a person you can make them normal, but you can approach that and get pretty close to it with spinal surgery. Again, when you're doing surgery, admittedly, you are changing the structure and anatomy of the spine. You're removing something or adding something. So the spine is a little different than what it was when you were born. But with successful surgery, and depending on the extent of the surgery, you can return some people to a normal lifestyle, or certainly pretty close to it.
Now, we talked about in the beginning about the T-lift procedure itself. We're going to show an animation now of what is involved in that particular surgery. So let's focus on the animation.
During the T-lift procedure, the patient lies face down on a bed designed especially for the procedure. Through an incision on your back, the surgeon begins by accessing the section of the spine that needs to be fused. First, any bone spurs and disc material pressing on the nerve is removed, and the opening around the nerve enlarged. Then the surgeon will remove almost the entire disc between the vertebrae to create a clean space for fusion between the bones. If the disc has collapsed from disease, the vertebrae are moved back into a normal position. The surgeon then prepares the area where the disc was removed so that the spinal implant can be placed for support. After measuring the size of the space, the surgeon inserts an implant made of bone or a synthetic material into the disc space. This implant gives critical support to the spine and aids bone fusion. The surgeon then places bone graft or other special material into the space around the implant to stimulate bone growth, which will take several months. Then, on the back part of the vertebrae, small screws called pedicle screws are inserted into the bone, and connecting rods are inserted into the screws to give the spine extra stability. This holds everything in place as it heals and allows for more activities after surgery. Over time, the vertebrae will grow together or fuse. After surgery, patients typically stay in the hospital 3 to 5 days.
Well, Dr. Butler, that was an interesting animation. There would be great value if you would take us through with your models and show us the steps of the procedure that you perform.
Sure. This is a model of a normal spine, and it shows the various areas of the spine that we look at. The spinous processes, which are in the middle of the spine, the small joints called facet joints, and then from a side view, the vertebrae, the disc, and the nerves, which come off of the spinal cord and go down the legs. During the procedure, after we've performed a CT scan using the O-arm navigation device, we now have images registered on a monitor that show us a 3D picture of the spine from the side, from the front, and from the top. The first step is to insert a pilot hole into the pedicle, or that portion of the spine that is connected to the front of the spine and the vertebral body. We are able to look at a live, real-time picture of our instrument used to make a hole in the vertebra before we insert the screws. We can check the positioning of that guide, if you will, before we actually insert the screws to make sure that it's not too close to the spinal cord or spinal nerves. We then remove our instrument. We see our pilot hole, and we've checked it using the image guidance. if you didn't have image guidance, you're not sure, one would not be sure that the pilot hole is correctly placed. We then insert a screw called a pedicle screw into the vertebra through the pilot hole, and with the aid of image-guided navigation, we actually see the screw turning, going into the bone millimeter by millimeter. When we finish, the screw is placed within the bone, and then we connect the screws with a rod that has a lock nut. Some surgeons prefer to put the hardware or screw and rod on one side, but we've done studies that show mechanically it's more structurally sound or stronger if the hardware is placed on both sides. It's braced twice, in other words. And that is the insertion of the hardware in the back of the spine. So there are two steps essentially when you do TLIF surgery. The first is removal of the disc and insertion of a cage that we fill with the person's own bone or some type of bone graft substitute in the disc space itself. So when we look at it on an x-ray, it looks sort of like this. Then the second step is the placement of the pilot holes, the insertion of the screws, and then the attachment of the rod to the screws.
Now, when people hear cage, when patients hear cage, we have a lot of different misconceptions, myself, a misconception of what exactly that is. This is actually, these are examples that you brought today of the cage which is put in the vertebral space.
That's correct. A cage, the term cage is sometimes misunderstood. It's merely a spacer in which you insert bone or some type of material that takes the place of bone in order to try to get bone to grow. It can come in different sizes and shapes. It can be round, it can be like a half moon or cylindrical. And the most commonly shaped cage when we're doing TLIF surgery is a rectangular cage. The reason that it's shaped like a rectangle is you have certain limitations on how much room you have to insert the cage as it goes past the nerves that are leaving off the spinal cord.
Because you don't want to touch those.
Because you don't want to touch or injure the nerve during the process of inserting the cage. There are other shapes, such as this one, that's a half moon shape, but that's too large to be inserted from the rear, so this is more commonly inserted from the front of the spine.
Right. In our next slide, we actually take you through the steps of the spinal insertion.
Yes, what we do is we have to remove a certain amount of bone in the area of the facet joint in order to gain access or to be able to see where the disc space is. And then using image guidance and looking at the anatomy, we try to remove as much of the disc as possible. Since we're doing a fusion, the disc is really no longer needed. So the more disc we can remove, the greater the surface area we have between the two vertebrae to put bone and to put a cage to get the bone to grow from one vertebra to the next. That's what a fusion is.
Right. And on our next slide, we show the complete insertion. And we're getting towards the end of the case now, aren't we?
That's correct. After the insertion of the cage, then we insert the pedicle screws and the rods that connect the pedicle screws. When we finish our portion of the surgery done in the front of the spine, if you will, inserting the cage, we do whatever work we need to do to decompress or relieve pressure on the nerves, and then we insert the screws and the rod.
All right, and we talked about the advantages of this. Of course, navigation gives you much better visualization, 3D. You have a CAT scan in the operating room, which is an amazing technology. Potential to shorten the case, which is what your experience has been, minimizes the use of anesthesia or the length of time that the patient's under anesthesia, and reduction in blood loss. So all of those things are critically important to a speedy recovery or a more advanced recovery. So if we looked at some of the advantages of this techniques over others, what would you say?
The first and most important thing is that using image-guided technology shortens the operative time. We know that the longer a person is under anesthesia, the greater the risk from prolonged anesthesia, likely the greater the blood loss, and also the longer that a wound is open, the greater the risk of infection.
Sure.
So the first thing is reduced operating time. The use of the TLIF procedure increases the success rate of a fusion. Not all fusions heal properly, and not all fusions heal at the same rate. We found that by using the TLIF technique and using hardware, that we have an increased likelihood of a successful fusion in a shorter period of time.
And those are incredible advantages of this procedure. We know that before surgery that you're going to have studies, maybe some physical therapy, some medication management, sometimes spinal injections in the pain. You recommend to patients if they feel more comfortable getting a second opinion, go get a second opinion, see what different surgeons look at things differently. And then before the case, of course, they would have to have surgical clearance. So what about recovery?
Well, I'll expound on what you just said. First and most importantly, the patients need to understand, and the public needs to understand, not everybody needs to have surgery. The majority of patients can be treated without surgery, as you mentioned, with different modalities of what are called conservative measures. Recovery varies depending on how extensive the surgery is. I do believe that patients have a speedier recovery with the use of the latest technology because they have less pain postoperatively and they're able to be more mobile, or they can get around earlier and faster because they have less pain. But recovery may take anywhere from 6 weeks to 3 months, depending on the age of the patient and the extent of the surgery.
Absolutely. And Dr. Butler is one of the few surgeons in the area that has access to this advanced technology, and he's considered one of the preeminent orthopedic surgeons in 3D navigation in the field. Also teaches at Tulane University Medical School. So from all of us at HealthQuest, Dr. Butler, we thank you so much for coming today and explaining this fascinating technology that helps patients recover faster, relieves pain, and it improves their quality of life. So from all of us at HealthQuest, we thank you for watching today. Have a healthy day.